What I would like to do is to talk to you about some of the things from a functional standpoint that I think are really important and that the evidence tells us are important when dealing with folks that are in the geriatric set. My objectives are here to kind of outline for you the scope of functional compromise in the aging population, look at some specific physiology, look at some evidence-based approaches to assess function and to provide treatment and give you a little bit of a framework on what to do with these folks. I don't have any disclosures other than the fact that I'm a member of the MOA and the AOA and several other state associations, but I don't have any other conflicts of interest that I'm aware of. So why should we be concerned with this? Well, it's to preserve quality of life and decrease costs, certainly. We know that the geriatric population takes up a lot of expenses of healthcare in our country. We know that 16% of the population of our country is over the age of 65. It's going to be 18% by 2020. And the greatest increase of that population is going to be in those folks who are over 85. We also know that between now and 2030, which is not that far away, the fastest growing segment of our population is going to be in the 65 to 74 group. By 2030, between 2030 and 2050, every 9th American will be 75 or older, and every 6th American will be 65 or older. In the 20th century, the number of people over the age of 65 increased 11-fold. And it's projected that in the first 50 years of this century, it's going to increase another 11-fold. So this population is rising rapidly. And if I were and I do give advice to medical students about what kind of careers they might consider. I tell them that for sheer raw numbers, in terms of job security, geriatrics is where it's at because there is no shortage. And in fact, we're going to have a tsunami as those of us in the baby boomer age range, and I'm a proud member of that group, get to the point where we're into the geriatric range. So we know that we're living longer, and as we live longer, problems, particularly with chronic issues and illnesses that affect function, get to be more of an issue, and activity limitation gets to be more of a potential problem. To quote one of my rehab colleagues, he said that as we are adding years to life, we have to give some extra effort to add life to those years, and that's really what it's all about. 50% of the people who are over the age of 65 who are living in the community use an assistive device, just to give you a perspective of where we're at functionally. What's happening is that with this group of people living longer and longer, we're having people surviving things, thank you Carol, that never were issues before, or not as much of issues as they are now. People are surviving those heart attacks, they're surviving those strokes, they're surviving all those issues, and so we have lots more people having lots more chronic illnesses. And those things cost money. But what is interesting is that it's not aging that's expensive, it's dying that's expensive. Because most of those costs happen in the last few months to weeks of life. So the problem really is that there's more people in this age group, but there's also a problem with, as has been pointed out previously, there is still, it's getting better, but there is still a dearth of physicians who are interested in and getting training in geriatrics and practicing in geriatrics. That's changing, but it's still an issue. There is still bias against elderly. There are still misconceptions that things like, well, anemia, well, you're a little anemic, but you're 70 years old, so that's, you're getting older, so you expect anemia. No, anemia is never normal at any age. Never, ever. And there's good evidence to that effect. We know, for example, that half of the people, the evidence tells us that half of the people in nursing homes in the United States probably don't need to be there because of either a reversible condition or an undiagnosed condition, or because of preventive disability that is preventable by some sort of condition. That's a problem. So instead of being inactive like we are now as a country, we need to be more active. The other thing is there are racial and ethnic disparities among older Americans. The further along we go, the fewer white Anglo-Saxon Protestants, or Caucasians that we're going to have in this age group. The non-Hispanic population over the age of 65 between now and 2050 is going to drop by 22%. The rise is going to be greatest in Hispanics, blacks, and Asians. So what do? Well, we continue doing good medical prevention, certainly. It's not that technology is not a good thing, and we do good prevention, but I think we need to give some effort toward prevention and restoring function. Now, we all learned in medical school that when you get older, certain things happen. Lean tissue goes down, bone mineralization goes down, fat goes up. From a postural standpoint, all of us as DOs, I think like this, but certainly those of us in rehab, we're obsessed with this, that, posture and positioning, as we go about our normal activities of daily living, really do impact our function. The head, as we get older, our heads move a little bit forward, our cervical spine extends a little bit more, we get a little more kyphotic in our thorax, we have our lumbar spines get a little bit straighter. We decrease the amount of flexion in our joints in our upper and lower limbs. Our arm swing goes down. Our step length gets less. We widen our standing base. The center of gravity moves on us. We sway a little bit with our posture. All of those things decrease to increase risk of a fall and of other safety issues. When you add these up, they don't add up the risk. Each one of those things is a risk. When you have multiple ones, they don't add up arithmetically, they add up logarithmically. So the more of these you have, the greater the potential problem. This is essentially a diagrammatic version of what I just told you. So how does this impact function? Well, from a very simple standpoint, here are a few just examples. It's harder to see things like the clock on the wall or exit signs, room numbers. Can be something very simple, somebody just leaning back, looking up, and then all of a sudden they lose their balance and they're gone. Strength goes down. It takes greater amount of effort to do things. Proximal muscles get weak faster than distal muscles. It gets harder to do really common things. One of the things that we rehab docs are obsessed with is transfers, moving from one surface to another, going from one place to another. The most important transfer I would suggest to you to evaluate in your patients is the sit to stand transfer. How much effort does it take for someone to go from a seated position to a standing position? How much effort does it take? Do they have to grab onto a table? Do they have to grab onto the arms of a chair? How much time does it take? One of the things that I do when I'm evaluating patients is I time them going from sitting to standing, and I time them walking 6 feet after that. And I look at the time and how it changes over time from one visit to the next. Sometimes patients will say, oh, I haven't had any decline in function, but they're taking twice as long as they did in the previous visit to do the same thing, or they're having to push off of that chair arm or off of that table that's right next to the chair, that kind of thing. That gives me a clue that I've got to be more aggressive now about functional issues, and I've got to ask more. It gives me a clue to the kind of questions I need to ask about what kind of things are you having trouble with, so that I can determine their risk. These folks need to have firm seats in their chairs. They need to have arms on their chairs. Some of them may not have that. They may not perceive they need to because they've never needed them before, but they do now. And sometimes they do need to lean forward a little bit as they go to stand up to do that safely. So this functional compromise is caused by all kinds of things. It's caused by medical things, it's caused by depression and other mental status and cognitive issues and other emotional problems. It's caused by their environment. Put somebody in a non-stimulating environment, such as an understaffed nursing home, and these functional problems are going to accelerate rapidly, very rapidly. And then you have deconditioning. It's something we're all vulnerable to. We all know, if you don't use it, you lose it. It's easier to keep something moving after it gets moving than it is to start it moving. So physical inactivity is not good for people at any age. It's especially not good for folks in the geriatric age. So we need to keep them moving and find creative ways for them to keep moving so that we can at least slow down the decline that they have in their function and decrease the effect that they're going to experience from other comorbidities. If we look at some specific systems in our body in terms of how they change with aging, I think it's important to help us zero in on the things that are most likely to be problematic. In the neurologic system, visual acuity goes down, okay? Reaction to light goes down. The speed with which we change our ability to react to light and the amount of light we need goes down. Our ability to accommodate, our ability to pursue things and follow things goes down. It takes long. It's not that we don't do those things, but we do them more slowly, and so it changes our reaction speed. This is especially important for things like driving, for getting up in the middle of the night. Sometimes the least lit room in the house is the bathroom at night. But when folks get up at night to go to the bathroom, in this particular age group, that's the room that needs to be the best lit, actually, and that can be a problem. Their gait changes. Again, as I said before, the base gets broader, the step length gets less, strength goes down, sensation goes down. Sensation to light, touch, and proprioception. If you don't do any other sensory exam on this age group, if you do nothing else, check their sensation, their 2-point sensation and their sensation to light, touch, and proprioception. If you don't do anything else, look at those things. Those are the most telling, and they have the greatest impact earlier on functional compromise. And they'll give you an idea that the person is at greater risk. Our reflexes go down. Cognitively, we have problems with decreasing, remembering longer lists. I'm having that problem now. Sometimes, every day, I think, oh, well, there's another neuron that's gone. Their immediate recall is pretty good, but that old memory is great, but it's the new learning and the new memory that gets to be an issue. In terms of other functional things, there are lots of variations, though, we have to remember. Not every 65-year-old is going to have the same vision or hearing or heart or lung or whatever concern. So there's wide variations. One of the things that is common in this age group, as I said before, is anemia. The most common anemia in this age group is iron deficiency. The second most common is anemia of chronic disease. That's never normal. It's never normal. So screening for that, it's amazing what I find. Oh, I'm not anemic, I feel great, and I check their labs and they're very anemic. Slow GI transit time. This is very important. It's caused oftentimes by diminished fluid, a relative state of dehydration, and the patient doesn't even know they have that. Diminished fiber in their diet, fiber intake, along with diminished activity. If you increase activity, that will help that. You increase fluid, that will help that. Slowed hepatic biotransformation. The liver just doesn't work as well. It doesn't handle things as quickly as it used to. And that means that medications aren't cleared as quickly and dosages need to be adjusted, particularly things like tricyclics and the major tranquilizers and those kind of things. So we have to be careful with those things. We have to be careful realizing that this age group, they have diminished reserve capacity. The shoulder on their road gets smaller and smaller and smaller. One of the things that I sometimes tell medical students, you guys are young and healthy, you're driving along life on a 6-lane highway with a gigantic, huge shoulder. Some people that you're going to be taking care of are on a 2-lane highway with a very small shoulder. And then there's some of those people that are on a 2-rut country road with no shoulder and a 1,000-foot cliff on both sides. And on that road, it takes much less to cause a problem than someone on the big open superhighway. So I think it's important to keep that perspective. Our kidneys don't work as well either. They don't concentrate as well. They don't dilute things as well. Sodium issues are very common in this group, both low and high. So we need to look for that. That also has a huge effect on cognition. I got a patient very recently from a physician who told me that this patient was having cognitive difficulties. They were putting him in a nursing home and they wanted me to go do a functional evaluation and see what other issues there might be. Well, one of the things I looked at that hadn't been looked at was their electrolytes. The patient's sodium was 108. Well, I worked a miracle by reversing the hyponatremia. and the person did not spend any time in a nursing home. Easy stuff like that. Sometimes it's amazing. Decreased glucose tolerance. This is very common in this age group. Thyroid issues, both hyper and hypo, okay? Temperature regulation is a problem. These people get to be pretty poikilothermic. They take on the temperature of the environment around them. One of the worst problems that folks can have is to keep their home too cool in the wintertime. Anything below about 72 degrees in this age group, I want my wife to hear this, in this age group is not a good thing. I happen to be married to a reptile who really likes it really cold. But that's really important. So that's another thing to consider from a functional standpoint. Other things, we know that the skin gets to be less moist and elastic. And we know, for example, that the cardiovascular system, we know that the heart rate goes down, we know that contractility goes down, we know that blood pressure goes up. From a urologic standpoint, we all know that frequency is more often, hesitancy, these kind of things. You need to check creatinine in these guys. See if that renal status is changing. Getting up in the middle of the night to go to the bathroom. Bladder capacity drops off, which contributes to having to get up in the middle of the night and do that more frequently. Creatinine clearance goes down. Incontinence is a frequent issue, and it's a very frequent issue in this group that not only it happens, but is a cause for them no longer being able to live at home. It can happen because of retention, it can happen because of overflow, it can happen because of detrusor issues, particularly overactivity of the detrusor muscle. It can happen because of mobility, it can happen because of cognition, it can happen because of a combination of all of those things. It can happen because of neurologic disease, metabolic disease, infectious disease, psychiatric issues, cardiovascular issues, pulmonary issues, GI issues. We need to rule out all those things before we think about, well, it's, such and such is just 75 years old. No, incontinence is never normal either at any age. Let's see. Sorry about that. From an exercise standpoint, we need to get these people more active, as I said before, okay? We need to maintain their range of motion. If you're gonna look at any range of motion of any joint, pick these three that I have listed here. The shoulder, the forearm, and kind of a combination, the hip and knee. They kind of work together. You want them to be able to abduct more and maintain as much internal rotation and flexion as possible. You want them to be able to pronate and supinate their forearms so that they can open doors, get jar lids off, those kind of things, and be able to flex and extend their hips and knees. Look for their cardiac issues, look for anemia, which can be a problem, and look for those thyroid dysfunctions. Quadricep weakness is very, very common. It can happen very insidiously. I check my patients' quadriceps strength every visit that are my ongoing chronic patients in this age group. That can be huge, checking their strength. It's amazing how you can, if you just do a gentle intervention in those areas, you can decrease their fall risk dramatically. From a drug standpoint, oftentimes we as well-meaning physicians contribute to this. We put people on too many medications. The average patient over 65 in our country is seeing more than 4 physicians. And in 75% of the cases, those physicians aren't talking to one another. They don't know what the other ones are doing. That's a recipe for disaster. It really, really is. And as the number of medications go up, you all know this, certainly side effect potential goes up as well. Substance abuse is not rare in this group. 1 in 5 are abusing substances. And by that I mean they're not taking them as they are intended for whatever reason. We all learned in medical school about the CAGE test in terms of using alcohol, those kind of things. But I would submit to you that the MASTER acronym is a good one to use in this particular group of folks when you're looking at their medications. Try to minimize the medications you have to use, the sheer number of them. Try to minimize the dose and ask yourself, when you're trying to figure out what you're going to prescribe and what you want to accomplish. Is there an alternative to this pharmacologic solution that I'm thinking of? Or is there a better pharmacologic solution? Start low and titrate and adjust the dose slowly, very, very slowly. Titrate therapy. Not only titrate therapy from a pharmacologic standpoint, but titrate non-pharmacologic therapy. If you decide to send them to physical therapy and you throw the book at them, and and it's very, very intense, at the end of the first day they feel like they've been hit by a Mack truck, their motivation to continue that's not going to be very good. So start slow, give them a chance to experience some success, make a big federal case out of it when they do, and then keep them moving on. Okay? Educate them. Here's why we're doing this. Here's why this is important. Here's the benefit that I expect to get from this. And then review your plan on a regular basis, because the best plan today may not be the best plan 60 or 90 days from now or a year from now, depending upon what their situation is. Really look at medications. I find oftentimes that my patients, when I ask them about their medications, they tell me about the stuff that people have prescribed for them. But then I ask them, well, what do you take that you get from the grocery store or the nutrition center or the whatever? And then the list just doubles. Well, we all know that there are huge interactions there as well. I always ask patients, well, how are you taking this? And compare it, what's on the label, to what they tell me. It's amazing how often those don't match up. Okay? So keep that in mind. Remember, 1 in 5 people over 65 have at least one medicine they shouldn't be on, that they should not be on across the country. 1 in 5. I would submit that you think about the continuum of comorbidity, frailty, and disability. Comorbidity being those things that work together, not for the patient's benefit, so that we can look at what all the comorbidities are, prioritize which ones are the most important to deal with and in what order, and do whatever prevention we can. Comorbidities add up because in our system, oftentimes these guys are in very fragmented care where the right hand doesn't know what the left one is doing. Disability, minimizing dependency, minimizing their social isolation, ultimately minimizing their concomitant mortality. And then comorbidity, if not appropriately dealt with, leads to disability. If not appropriately dealt with, leads to frailty. They're going to be vulnerable to stressors that would ordinarily have not been an issue for them. Treat those underlying problems and minimize any risks that you can. Doing a functional assessment, in my opinion, is a key thing to do. The mini mental status exam, we all know what that is. That's a great thing to do, but it takes a while to do that. But certainly there's no reason why you can't gather that data from time to time. I like the geriatric depression scale. It's not necessarily the best. You should be aware that there is a long form and a short form. I've supplied you on the next slide in the materials that you'll get with the short form. That's the one I use. It's been validated, works great. If you're using that just in an interview, it takes me about 2 minutes to do that. Sometimes I'll have them fill that out or have their family member fill that out before they come in. A special comment about driving. Driving is a huge issue for geriatrics. I know that when I get there, somebody is going to have to knock me on the head and pull those car keys out of my hand. Okay, that's just the way it is. I would suggest that you consider that driving could potentially be an issue if their near vision is not 20/40. That's what you really want it to be. You want them to have close to normal, doesn't have to be normal, but close to normal rotation of their neck and good visual attention, the ability to follow things and attend to things with their vision. And I would submit that those would be very high yield things to evaluate. If those things are getting to be problems, then they need to be addressed as potential, not only just medical issues, but driving safety issues as well. Balance. Balance is huge. As I said before, transfers in and out of a chair. The ability to withstand a sternal nudge. One of the things I do whenever patients get up out of that chair and I've timed them and they walk that 10 feet and I've timed them, I'll have them stand in front of me. I'll make sure that there's either somebody's going to be able to catch them if they need it, or I'm able to help them. But I give them a kind of a moderate nudge on their sternum to see if I can cause them a balance issue that they cannot recover from. That is, the evidence shows us that that is highly, highly specific to other risks for balance issues that are associated with fractures. Okay? The other thing you want to do is have patients reach up, okay? See what kind of, ask them what kind of things you need to reach up over your head for. And then how far up is that? And then see how they do and see if it changes their balance. And see if they can maintain their balance when they reach up overhead, and see if they can maintain their balance when they bend over. The thing they will probably not notice, but that will change more, is the reaching up. They will perceive that reaching up is not an issue, but you'll find that it happens so insidiously, that loss of overhead reach happens so slowly that they won't be consciously aware of that. I think it's also good to look at gait. Look at how particularly they initiate gait, going from a standstill to moving. They should not hesitate. They should not stumble. If they do, there's a potential problem there. Are they getting enough clearance of their foot to clear steps? At least 6 inches is a good barometer of most steps and stairs in the community. In most places are 6 inches. So you want to see if they can do that. It's also important to be able to flex the knee at least 80 to 90 degrees, because that's what you need to clear that 6-inch step. It's also important to have good knee flexion to walk and to have good clearing of the foot as it advances forward if they're walking on unlevel surfaces. And look at step symmetry. If the steps aren't on the right, aren't pretty much the same length as the steps on the left, that can be a problem. And then how well they do when they turn. So what I do, it takes me about 60 seconds to have them go, well, if they're doing really well, to have them go from sit to stand, walk 10 feet, do the sternal nudge, have them reach up, bend over, walk away from me, and I watch the step height and the step symmetry, and then have them stop on cue, and then turn around, face me, and walk back toward me. It takes 60 seconds. So it doesn't take a long time. Gives you lots and lots of data, however. Why is that important? We don't want these people to fall. 1/3 of people over age 65 will fall. 1/3, no matter what we do. Falls cause 90% of fractures in the hip, pelvis, and forearm. And in hip fractures, 50% of the people who get a hip fracture are dead in 2 years in this age group. 50%. That's huge. Be aware of problems with cognition. Be aware of inattention and depression. Depression is the #1 non-pharmacologic, non-physical risk factor for falls. And it's the #1 problem people are going to have if they live alone in this age group. So if people live alone over 65, screen them for depression. You'll be amazed how many people you will find that you did not perceive to be depressed. Look for visual impairments. Look for those neurologic things. Look for that musculoskeletal weakness. Check for postural hypotension. Look for gait issues. Look for hearing issues. Another thing I would suggest you do is give them a little tool on how to assess the safety of their home. Either they or their family can help assist with this. And I've provided you with several slides on how to do that later. Assess their visual acuity. Assess their hearing. Assess their other ear, nose, and throat things. Look in their ear canal to see if it's completely clear. If it's full of wax and they already have diminished hearing from aging and it's full of wax, now their hearing is even worse. Their writing reflex may be worse. That could be a problem with balance as well. Assess their nutrition. Look at vitamin B12 levels. Very high yield test to do there. Again, check balance and strength. In this group, it's really nice, if you can, to avoid anything that acts centrally or sedating. And if you have to use something like that, pick the shortest acting thing you can. A little gentle balance and gait training can go a long way to, it's a kind of an ounce of prevention is worth a pound of cure. So what do we do with the home safety? Here are some things I would suggest. I actually have a sheet in my office that I give to patients and their families with these things on. All of these things, this isn't everything I have on my sheet, but all of these things have been shown in the literature to have a significant relationship to fall risk. Each one alone is related to increased risk of fall, okay? So are the floors slick? Is there thick piled carpet? A lot of these guys still have the same carpet they had back in the 1970s when thick pile was really cool and everybody thought that was really great. But it's not a good thing when your balance is not good and when your gait's not great. Make sure that the right amount of lighting is present. Make sure to minimize glare. If they have stairs, make sure that the light switches are ideally at the top and the bottom of the stairs. Make sure they use night lights. I live in Tennessee now. NASCAR is very popular down there. I am blessed with the fact that they now make NASCAR night lights. That has increased my patient compliance more than you can imagine. Non-skid edges on stairs, and again, make sure the stairs aren't too steep. Look at handrails. They should be away from the wall at least an inch or two. Look at towel bars. Replace towel bars with those non-slip ones, the industrial strength grab bars. Make sure that if they evaluate, do they need a shower chair? Do they need a handheld shower? They may not know that they do. If you do some of those things I mentioned earlier in your office visit, you can get a pretty good idea if they need a shower chair or a handheld shower. Look at how high their bed is. Is it too high or too low? And ask about their mattress. When you sit on the edge of your mattress, I ask my patients, does it sag? Okay, it shouldn't sag. Because if it sags, it's going to be harder to get up off of without a balance problem. Look at the chairs. I give them an assignment. I want you to measure the chair height, you know, the distance from the seat to the floor. How high are the armrests? Do the armrests extend to the front beyond the seat? They should, particularly if people need to use them. Look at the shelf where they've got things that they use a lot. Maybe they need to take those things in the kitchen from the top shelf that they use a lot down to the bottom shelf if they're having those balance or postural problems. Make sure that the controls on the stove and the washer and the dryer and all those things are marked really, really well. And again, avoid hypothermia. These people they take on the temperature of the area around them, and hypothermia is their greatest enemy from a temperature standpoint. Pain issues impact function, and they keep people inactive. Most of that is musculoskeletal, so screen for that, particularly in the shoulder, the limbs, and the hip and knees, because that can also cause range of motion to go down, to get flexion contractures, and now mobility is going down. And then we also increase the energy expenditure that they have to exert in order to do routine activities of daily living, and they may not have the cardiopulmonary reserve to do that extra energy expenditure. So watch that. Swallow is really, really important. As we get older, it takes us longer to swallow. Swallow is incredibly complicated. It involves a finely tuned symphony of muscular contractions that have to happen in precisely the right order within less than a second. And as we age, that process gets messed up a little bit. People will begin to have trouble with thin liquids. They'll begin to have problems when they eat things of mixed consistencies. If they have thick things versus thin things at the same time, things with peels on them begin to cause problems. If I know that a patient is having difficulty with swallow, I advise them to alternate solids and liquids. Don't do solids and liquids at the same time. So if you eat something and you're chewing on it, swallow it before you take a slug of whatever you're drinking, okay? And double swallow. Double swallow. It's amazing how powerful these simple things are, alternating solids and liquids. Don't mix consistencies. Double swallow. And forward flex the neck just a little bit when you're swallowing. We use those in inpatient rehab units all over the United States for people who are at risk for dysphagia or have documented dysphagia. A quick dirty thing you can do is you can give a patient any thin liquid to drink, ask them to drink it, take a couple of swallows, and then immediately ask them to phonate. Make a vowel sound like E or A or whatever. If it sounds wet, you've got liquid going down the wrong way. You've got enough evidence right there to go, gee, maybe I should get a swallow evaluation. Maybe they're aspirating silently and they don't know it. This could, if a person has a problem with swallow, they could be at risk for aspiration pneumonia, which is 50% fatal, folks. 50% of the people who get that die. There's not a thing we can do about it. So we want to avoid that, if at all possible. Arthritis. We all know that osteoarthritis, rheumatoid arthritis, and other arthritic conditions cause problems, particularly with range of motion and strain. Osteoporosis is a huge problem with pain. It can cause pathologic fractures. You all know that. Fractures can be really, really functionally limiting, can be the beginning of a downward spiral medically and functionally. Stroke, brain injury, incontinence, as I said before, look into those other things. Sleep disturbance, endocrine disturbances, particularly thyroid disturbances. People who have brain injuries, particularly traumatic brain injuries, have a host of endocrine issues and complications. So if you have anybody in your practice who has had a traumatic brain injury, just look into the endocrine, just the endocrine alone. It'll amaze you what kind of issues that you might need to look for. I list several different types of diseases so that you can get an idea of some of the things that affect function that are associated with them. Motor neuron diseases and Parkinson's disease frequently affects swallow, frequently affects people's ability to do self-care and causes respiratory problems and makes them at risk for aspiration. Peripheral nervous system issues there from drugs, from toxins, from alcohol, from various neuropathies. All the rheumatic diseases can cause those things. Metabolic diseases, cancer, a whole host of things. Visual issues are obvious. Skin issues, pretty obvious. Lymphedema, a huge contributor to diminished gait, diminished balance, diminished proprioception. Depression. Everybody in here probably already knows this, but depression is huge in this population. Over age 65, depending upon whose data you look at, between 16 and 30%. And that's people who don't have other comorbidities. That's just people over 65. That doesn't include people who have heart disease, pulmonary disease, whatever. That's the healthy 65-year-olds have 16 to 30%. When you start adding cardiovascular disease, pulmonary disease, neuromuscular disease, et cetera, the frequency with which these folks experience depression gets worse. Okay? If they have functional dependence, the risk is increased threefold. Any functional dependence increases that risk threefold. Watch for mood changes. Watch for people who lose interest in the things that they really used to love to do. You know, I had a patient recently who I asked her, so how often are you playing bridge now? And she goes, yeah, I don't play bridge very often anymore. Because she used to play twice a week. I said, well, why are you not playing bridge? Is there something wrong with your car? No, my car's fine. Did anybody move away? No. Did you have a fight at the last bridge meeting? Somebody getting real cutthroat on bridge? No. It's just not as much fun as it used to be. Or it's too much trouble. Now, this is a person who used to be obsessed with playing bridge. This woman's depressed. She's depressed. Motivation, fatigue. People who aren't interacting with the world like they used to. People whose appetite is changing. People who complain of sleep issues. Be really careful using medications with high anticholinergic activity with people with depression. Be very, very careful with that. Anxiety, very common in this age group. You want to be careful that you differentiate between what is actually anxiety and all those things that due to medical illness or medication that can create anxiety. The differential diagnosis for anxiety is gigantic. But just some of the things, I'll just list a few here, that are common in this age group. Alcohol abuse, sleep apnea, asthma, atrial fib, delirium. Delirium is another huge one. Depression, diabetes, DIG toxicity, calcium issues, irritable bowel disease, schizophrenia, personality disorders, esophageal motility issues, fibromyalgia. How many people in here have a patient over 65 with fibromyalgia? Yeah, that's very common. Unstable angina, thyroid disease, huge things, huge things. People who take theophylline or drugs like it, people who take steroids, people on antivirals, all of those things can cause anxiety. Delirium, huge differential diagnosis there as well, okay? The key to delirium is that delirium is acute. Delirium is not chronic. My good friend back there, Dr. Harris, taught me that. Delirium is not chronic, it's acute. If it lasts longer than acute, it's not delirium, it's something else. It's something else. They will have attention disorders if they have delirium. They will have disorganized thoughts if they have delirium, okay? And then dementia, good Lord. 20% of people over 80 have dementia of some sort. We all know what it is. I've listed it there. But there are some really reversible causes of dementia, such as thyroid disease, calcium dysfunction, niacin B12, drug toxicity, depression, subdural hematoma. I have a patient who about a year ago I saw them in an inpatient rehab unit on consult because of advancing dementia. And on my physical exam, I said, after my exam, I said, I think we need to image this person. Have they fallen lately or anything like that? Well, they took a fall in the garden, but everything's okay. They didn't hurt themselves. They didn't lose consciousness. They had a subdural. So you got to look. Opioids, we have to be very careful with those. That low and slow is really important with opioids. And we need to anticipate side effects. If you put somebody over 65 on an opioid, you need to do something about the constipation that's going to ensue, and you need to increase their fluids, okay, beforehand. So begin that bowel program early. Be really careful with NSAIDs, be really careful with acetaminophen, and don't go over the maximum dose, and watch for GI and kidney issues. Watch for platelet issues. In the literature that says that those things aren't really common, that's for the 70-kilogram male research subject, okay? People over the age of 65 will frequently have those issues, so you need to watch for that so you don't get caught by surprise. Avoid long-time dosage of steroids. Be very careful with the antidepressants. Again, start low with the anticonvulsants, and if you're going to use anticonvulsants, be sure and check their CBC and their liver function. Be very careful with the antiarrhythmics. Very, very, very careful, because those can cause issues. So when it comes down to the brass tacks, when we really get down to the rubber meeting the road, what we need to do is, with these patients, if we don't already know, we need to ascertain what their baseline functional level is. And that's your barometer by which you measure all your future encounters. You want to avoid immobilization at all costs if you can. Be aware of the things that can impact their function. Be aware of those physiologic things that happen in this age group so that you can be proactive rather than reactive. Talk to the patient about what they want to be able to do. It's amazing what I have found sometimes talking with patients of any age, but particularly in this age, what sometimes their family wants them to do and what others around them want them to do is very different from what they want to do. If you get into a struggle between what the patient's goals are and what your goals are, guess who's going to lose? You. The patient will always win, but when they win, they may be the loser. So it's a great idea to, I think, and I was not taught that in medical school. I didn't learn that until my residency. Sit down, look at the patient, find out what's really important to them. Like when I found out that my patient's first priority was to be able to watch her 2-year-old granddaughter and to be able to pick her up and be able to follow her from room to room and hold her without falling. Okay, now we've got a goal. Now I know what this patient really, really wants. And now I can set up a program that she will be very invested in because everything in that program will be geared toward helping her accomplish that goal. How long will she be able to do that goal? I don't know. But at the beginning, I don't care. I just want to get her to that goal. Okay? So you do have to sometimes think about family as well. Be sure and differentiate between delirium and dementia and depression. Don't get those mixed up. Emphasize function. Manage function issues. Make sure that your exercises and things that you do from a therapy standpoint are very specific in terms of goals and tasks. Encourage these guys to stay socially active and stimulated. Minimize their medications. Get rid of stuff if you can. And remember that these improvements are going to happen slowly. You're not going to reinvent the wheel overnight. Okay? The other thing I wanted to share with you just as a final is the domain management model of Stevens. This was developed in 2010, and it's kind of an outline of an approach to geriatric functional issues, looking at medical and surgical issues, then looking at the mental and emotional issues and coping strategies, then looking at physical function, breaking that down into basic activities of daily living versus intermediate and advanced. And the basic ones are the first priority, intermediate are the next priority, and the next ones are advanced. You want to get the basic ones as good as you can before you go on to the next one. And then looking at their specific environment that they live in, which may be more than one place in our very mobile 65 and up group. Sometimes there's going to be an environment. I found this I learned this actually when I was living in Michigan. You know, if you ask somebody about their home and what it's like and everything, you have to ask, okay, now is that the only home you live in? Oh no, then there's the house in Florida or Tennessee or North Carolina or whatever. So, or they go and visit with their children or grandchildren, you know, that kind of thing. I have a few patients who are kind of gypsies and they get in their little car and they have 5 children, so their year they divide it up into 5 locations. And so I have to know about those things as well. So find out where it is they live their life, because that is how you'll find out what's important to them. And that is the key to keeping them functionally optimized. And that is the key to optimizing their quality of life. Questions? Thank you very much.